Hey everyone, and welcome to today's Explainer. We're jumping right into a really fascinating modality today. It takes something totally natural, invisible heat, and transforms it into this incredibly precise, powerful clinical tool. We're talking about infrared radiation therapy, or IRR. Now, it's pretty much a cornerstone of physical therapy, but honestly, the underlying physics and the physiological cascades it triggers in the body, they're just absolutely captivating when you really dig into them. Okay, let's just dive right into our outline for today. We're going to move through this systematically. We'll start with the science of infrared, then look at how we actually produce this therapeutic radiation. After that, we'll cover physiology and penetration, the real-world therapeutic uses, the practical step-by-step application, and finally, we'll wrap up with the crucial dangers and contraindications.
So, kicking things off with Section 1, the actual science of infrared.
So, what exactly is infrared radiation? Well, from a science perspective, it's a band of electromagnetic radiation. It has wavelengths that are just a bit longer than the red end of the visible light spectrum, spanning from about 760 nanometers all the way up to 1 millimeter. Now, here's a kind of wild fact. Infrared is completely invisible. It has no visible color whatsoever. It's literally constantly being emitted and absorbed by any warm object in the universe. That includes your own body right now. And because it's invisible, we humans only detect this specific band of radiation purely through its heating effect on our sensory receptors. You know, we feel it, but we definitely can't see it.
Now, when we're in the clinic, we have to be way more specific than just saying, okay, let's apply some heat. Infrared is actually classified into 3 distinct regions based on its wavelength. First up, we've got IRA, which runs from 760 to 1400 nanometers. This lines up perfectly with the older but honestly still super common textbook term near infrared. Then there's IRB, spanning 1400 to 3000 nanometers, and that maps directly to far infrared. Finally, IRC takes us the rest of the way to 1 millimeter. But here's the key takeaway. In a therapeutic setting, we're almost exclusively utilizing those A and B regions, the near and far infrared bands, to actually get the clinical results we want.
Moving right along to Section 2, producing this therapeutic radiation.
To actually generate these specific wavelengths, we generally rely on 2 types of equipment, luminous and non-luminous generators. Luminous generators use a tungsten filament housed inside a glass bulb. These things operate at incredibly high temperatures, putting out mostly near-infrared, a little bit of visible light, and even a tiny trace of UV that just gets blocked by the glass anyway. Because it's near-infrared, it gives you much deeper tissue penetration. On the flip side, we have non-luminous generators. These usually use a resistance coil that's embedded in some kind of insulator, like fire clay or porcelain. They emit far infrared, which creates a much more superficial heat. But here is the massive, absolutely crucial practical distinction you need to remember. Non-luminous lamps take time to warm up. Because of the thermal inertia of that ceramic material, you literally have to switch the machine on 5 to 15 minutes before your patient even walks into the room.
All right, let's get into Section 3 and see how this builds. Physiology and penetration.
So, what's actually happening when these waves strike the human body? Well, as this diagram brilliantly illustrates, there's a profound difference in penetration depth depending on the wavelength you're using. Near infrared, so those shorter wavelengths coming from our luminous lamps, right around 1000 nanometers, can penetrate up to 3 millimeters deep. That means it reaches right down into the dermis and hits the blood vessels. But far infrared, the longer 3000 nanometer waves from the non-luminous lamps, has a penetration depth of only about 0.1 millimeters. You might be wondering, why such a huge difference? It's because water and proteins are incredibly strong absorbers of infrared. So the far infrared gets absorbed almost instantly by the water, sitting right there at the very surface of the epidermis.
Now, once that radiation is absorbed, it kicks off a massive physiological cascade in the body. The heat essentially triggers the release of chemical vasodilators like histamine, which leads to increased blood flow. But here's an interesting quirk. Unlike the smooth, even redness you'd get from being out in UV light, infrared produces an irregular, patchy erythema. It's a very direct, visible sign of arteriolar vasodilation. Basically, some arterioles dilate and gorge the capillaries they supply, while the ones right next door don't, giving the skin this mottled, patchy look. You're also going to see a spike in local tissue metabolism and, depending on how intense the heat is, some mild to moderate sweating, which is really just the body's natural attempt to cool the surface down.
Which brings us to Section 4, therapeutic uses. Why do we actually want to provoke these effects?
The clinical indications for IIR are incredibly practical. First and foremost, it's about pain relief. Applying mild heat has this beautifully sedative effect on superficial sensory nerves, which is just perfect for acute injuries.
On the other hand, a stronger heat can act as a counter-irritant, which is a great strategy for tackling chronic pain. Secondly, we know muscles relax most readily when the tissues are warm. By increasing that blood flow to flush out metabolic waste and easing the pain, infrared perfectly primes a patient for further treatment. In fact, one of its absolute best uses is preheating. You do this prior to a massage, stretching, exercise, or even electrical stimulation, because it makes the skin more vascular and a much better conductor. Plus, it's fantastic for boosting blood supply to superficial wounds to really accelerate that natural healing process.
Okay, moving to Section 5. This is the how-to, the practical application steps.
Setting up an actual IRR treatment requires a lot of precision. Step 1, like we talked about, if you're using a non-luminous lamp, turn that thing on 5 to 15 minutes early. Step 2, and listen, this is completely non-negotiable. You must test the patient's skin sensation to hot and cold before you apply the treatment. If they can't accurately feel heat, you cannot treat them. Period. Step 3 is positioning. You want to arrange the lamp so the rays strike the skin at exactly a right angle. This ensures maximum absorption and cuts down on reflection. You'll generally want to measure the distance to be somewhere between 50 to 75 centimeters away, depending on the lamp's wattage. And finally, Step 4. Apply the treatment for 10 to 20 minutes. But don't just walk away. You have to remain nearby, checking in on the patient periodically, because the thermal output of these lamps can slowly drift upwards over time. By the end of the session, you should be seeing that patchy urethra we mentioned, and the skin should feel moderately warm to the touch.
Finally, let's look at Section 6, dangers and contraindications.
Look, as with any powerful clinical tool, understanding the risks is just as important as knowing the benefits. Heat burns are obviously the most apparent danger here. This usually happens because a patient has defective sensation, maybe they shifted too close to the lamp, or they literally fell asleep during treatment. But check out that third point, gangrene. This is a severe and honestly surprising risk. If you apply infrared heat to an area that has a defective arterial blood supply, meaning the arteries can't dilate properly to bring in cooler blood and dissipate the heat, you literally end up cooking the tissue. And that leads directly to necrosis and gangrene, no way around it. Also, extensive irradiation can cause a systemic drop in blood pressure since the blood starts pooling in those dilated skin vessels, which can make the patient feel faint. And, for sure, you absolutely must protect the patient's eyes to prevent cataracts or corneal burns.
Because of those very real, very severe dangers, we have strict, absolute contraindications. You must never, ever apply infrared radiation to patients with impaired thermal sensation or defective arterial circulation. Like we just talked about, the risk of burns and gangrene is just way too high. You also can't treat patients with a lowered level of consciousness simply because they can't accurately tell you if they're overheating. We also steer clear of areas with acute dermatitis or eczema because heat just aggravates acute skin inflammation. Same goes for areas that have had recent deep X-ray therapy. And lastly, never treat a patient with an acute febrile illness because their body's temperature regulation system is already working in overdrive and under immense stress.
So, what does this all mean? Infrared therapy is literally the application of invisible, radiant energy directly into human tissue to forcefully manipulate blood flow and metabolism. It heavily accelerates the body's own natural healing mechanisms in a really profound way. But, as we've seen, it demands absolute respect for the physics involved and the physiology of the patient sitting right in front of you. Does the profound benefit of accelerating natural healing outweigh the critical risks of applying this invisible radiation? Well, when it's applied with the precise structure, distances, and strict safety checks we've walked through today, the answer is a resounding yes. Thank you so much for joining me on this explainer. Keep learning, stay focused, and I'll catch you in the next one.